Very warm welcome. I am Dr. Masood Khan. Today we will take a history and present a history of long case. Mr. Owais, son of Muhammad Shah, 22-year unmarried, working as a shopkeeper, resident of Balochistan, admitted via OPD in Jinnah cardiac ward. Presented with complaint of fever off and on since 1.5 months. According to the patient, he was alright 1.5 months back. Then he started having low grade fever, recorded 101 to 102 degree Fahrenheit, off and on, but usually low grade fever. And since then it is increasing in duration, present every day, aggravated not by any specific thing but relieved by antipyretics. However, patient used to have a feeling of increased tiredness and lethargy upon exertion and doing normal household works. Fever is associated with generalized weakness. Patient denied any cough, loose stools, night sweats, weight loss, rigors and chills, shortness of breath on exertion or palpitation, lumps and bumps anywhere in the body. The lethargy is worsening. 2 weeks back he was able to walk, but since 2 weeks he is extremely tired all the day and he is unable to have his normal household works. Patient denied any paroxysmal nocturnal dyspnea and any orthopnea. No associated focal neurological weakness, headaches, numbness of any specific area. Patient also denied frothy urine, any facial or pedal edema. There are no tender points and there is no arthralgia, no swelling, no loss of vision, sensory or motor dysfunctions. There is no history of any tattoo marks, IV drug abuse, high risk sexual behavior, blood transfusion, continuous IV cannulation, and no prolonged hospitalization. Past history is insignificant, no previous surgical or medical ward admission. There is no history of allergy to pollens, dust, any factory fumes. Patient has used some IV and oral antibiotics during last 1.5 months and paracetamol tablets prescribed by his local doctor. There is no history of tuberculosis, malignancy. There are 3-member family living together. His father is the main breadwinner for the family, and they belong to a middle class family. The oral hygiene is maintained and personal hygiene is also maintained. Patient denied any monthly use of IM injections. Upon admission in cardiac ward, There he was investigated, so his echo was done, and he was told that he is having some valvular pathology, and the other workup is still awaited. He has been advised some IV antibiotics. Upon history, my differential diagnosis includes, on the top is there is a fever with murmur and valvular pathology confirmed on echocardiography. So my top differential is infective endocarditis. Number 2 is pyrexia of unknown origin, and number 3 is tuberculosis, as it is very common in our part of the world. Now a question arises that why it is infective endocarditis? Why not rheumatic heart disease? Patient denied any history of childhood repeated throat infections, and this is the first episode. So for further clarification and understanding, we need to ask some more questions in these patients to confirm the fever with fatigability and its causes, because the differential diagnosis of fever is broad. So according to the first of all, the fever pattern, it is continuous in this patient since 1.5 months, and the fever never touches the baseline. However, it was temporarily relieved by Panadol or paracetamol, and my patient is not having any risk factors. So, and there is no history of cough, altered bowel habits, post nasal drip, running nose, redness in the eyes, discharge from ear, nose, any lumps and bumps in the body, and there is no previous intervention or in the body like dental interventions. There is no history of cyanotic congenital heart disease or any valvular heart disease. So the differential diagnosis about fever in this patient is, first of all, we have to rule out the cardiovascular system, that any chest pain history. There is no chest pain history in this patient. Shortness of breath that increase on lying flat or awakening from sleep at night. Patient denied any history of palpitation. Now fever, as a second system, we have to rule out the respiratory system. There is no history of cough, any whistling sound in during respiration, no history of any use of inhalers. So CNS system, there is no history of altered sensorium, fits, neck stiffness or weakness of any part. Abdominal history, if the GI system, we rule out. There is no history of tuberculosis, weight loss, decreased appetite, abdominal distension, altered bowel habits. The rheumatological system should be screened on history, like there is no arthralgias, bruisability, There is no history of significant travel. There is no history of drug abuse. There is no history of high risk sexual behavior. And further screening includes there is no discharge for eye, ear, and nose. There is no oral ulceration, skin rash, joint deformity, or genital ulcers. So there is no history of photophobia, phonophobia, and there is no history of malignancy. All these are causes of fever we have to rule out while history taking. There is no history of prolonged immobilization, unilateral limb swelling, and DVT, and there is no history of bleeding from gums or any part of the body. Now, in this patient, the pure symptom which he presents is fever since 1.5 months, which is continuous, progressive, and it has never touched the baseline, although relieved by paracetamol. So, the history comprises of this pattern, and here we have to rule out the complications or associations in this case, like IV drug abuse, dental procedures, congenital heart disease, any prosthetic valves procedure, any interventions like cardiac catheterization or repeated IV cannulation. We have to rule out autoimmune disease because it is associated with certain like infective endocarditis, the Liebman-Sack endocarditis, Marantic endocarditis associated with malignancy, and there is no exposure to animals. Brucellosis can present as infective endocarditis. There is no history of endoscopy, cystoscopy, bronchoscopy. All are risk factors leading to infective endocarditis. So these are risk factors, and there is no such risk factors. Now, what are the complications? Complications of infective endocarditis: hematuria, hemoptysis, diarrhea, splenomegaly, left hypochondrial heaviness, weakness of any part of body, that is sudden loss of vision or sudden loss of power in one limb. Painful skin rash is very common with infective endocarditis, and blood in the eyes, that is conjunctivitis, is very common. So these are the points rotating around the cause of the fever we have to rule out. Now, what labs we ideally should do in such patients? That is the baseline screening, that is CBC, complete blood count, ESR, C-reactive protein, the inflammatory markers, urea creatinine to assess the renal functions, chest X-ray, electrocardiogram, and echocardiogram. In this patient, echocardiogram shows valvular lesion, and he was advised that he will be having prolonged hospital stay around 2 weeks to 3 weeks. So this patient upon history is suggestive of infective endocarditis. Now, fever with valvular pathology, and upon examination, patient has positive findings of vitals, like he is having hypertension, 180 millimeter of mercury systolic and 120 diastolic. Patient may have clubbing, but in this patient it is negative. Oscillar nodes, but it is negative here. And jaundice, splinter hemorrhage, all are negative. The peripheral stigmata is positive in only 25% cases in infective endocarditis. Now, the cardiovascular system, upon examination, there is an MR murmur. The MR murmur is best audible at the left fifth intercostal space, mid-clavicular line. It is pan-systolic and radiating to the axilla. Beside these, we have to auscultate the lung basis and check the sacral edema, and also the cranial nerve examination, especially the seventh cranial nerve. In abdomen, spleen is mandatory. Splenomegaly is often associated with infective endocarditis. Ascites is positive most of the time with infective endocarditis. Lower limb motor examination is mandatory if we are suspecting infective endocarditis. Fundoscopy is mandatory. Now, the infective endocarditis further discussion includes that whether it is of infectious cause or non-infectious cause. Infective endocarditis is further classified into acute infective endocarditis or subacute infective endocarditis. Now, the viva questions which are often asked, that what are the infectious agents that leads to infective endocarditis. On the top it includes Staph aureus, then Viridian streptococcus, then HESEC group, that is culture and sensitivity negative group, the HESEC group. Non-infectious infective endocarditis includes autoimmune diseases like systemic lupus erythematosus, rheumatoid arthritis, and malignancies. These are also culture and sensitivity negative. The blood CS is negative. Upon further discussion, there is a criteria for diagnosis, the Duke's criteria or modified Duke's. Major criteria includes the blood culture and echocardiography. The minor criteria includes fever and vasculitis or vascular changes. So 2 major and 1 minor is a confirmatory for induced criteria. CBC includes anemia, raised WBC, and reactive thrombocytosis. Blood cultures should be taken 10 to 20 milliliter from different sites, 3 sets, and the 3 sets of culture, 2 should be positive. ECG includes the PR prolongation secondary to aortic root dilatation, And PR prolongation, it denotes aortic root dilatation. Echocardiography, especially the transesophageal echocardiography, it shows small vegetation and abscesses in prosthetic valves. Now, question arises: if culture and sensitivity 3 sets negative, then infective endocarditis, how we can rule out? Yes, there is a possibility, like Hasek group, brucellosis, Bartonella, and patient might be already on antibiotics. Therefore, the culture and sensitivity results, they are often negative if they have used antibiotics before. Another question, that is there any role of colonoscopy in infective endocarditis? Yes, there is a role. The Streptococcus bovis detected on colonoscopy specimens, that bovis, Streptococcus bovis, can cause infective endocarditis. So, which antibiotics should be used prophylactically in a patient with suspected infective endocarditis? The coamoxiclav injectable 2 gram state, or uh, if patient is penicillin allergic, then clarithromycin or azithromycin should be started. Now, prevention in case of infective endocarditis. What are the prevention measures of infective endocarditis? Number one is prosthetic valves. Number two is congenital heart disease repair. In these condition, we have to preventive, uh, we have to give antibiotics. So prosthetic heart valve repairs is within the 6 months. Congenital heart disease repair, transplant with valvular heart disease, we need to give lifelong uh, prophylactic antibiotics. Old infective endocarditis with residual valvular disease, also we give lifelong antibiotics and any residual changes in the valve. Now, the infective endocarditis organisms. Number top is Staph aureus, the MRSA, methicillin resistant Staph aureus. It can cause infective endocarditis in both native and prosthetic valves. So in this case, MRSA positive, we give vancomycin plus gentamicin for 4 weeks. If MRSA negative, if MRSA positive, vancomycin plus gentamicin plus rifampin for 6 weeks. But gentamicin is nephrotoxic, so it should never be given beyond 2 weeks. Enterococcus is another species of organism bacteria that leads to infective endocarditis. So in this case, we give ampicillin plus ceftriaxone. If penicillin sensitive, if penicillin responsive, vancomycin plus gentamicin for 6 weeks. And if gentamicin should not be given beyond 2 weeks. If gentamicin is resistant, then we opt for IV streptomycin and vancomycin. Now, Streptococcus bovis, again gentamicin for 2 weeks and then ceftriaxone. If penicillin resistant, uh, we have to go for the alternative regimes. HASIC, positive infective endocarditis, fluoroquinolone is advised for 4 weeks to 6 weeks. And fungal infective endocarditis, we advise surgery plus amphotericin B 6 to 8 weeks plus 5-fluorouracil. There are certain intracellular organisms. In that case, we use doxycycline with gentamicin followed by fluconazole for 6 weeks. So the important tips in the treatment is native valve infective endocarditis treatment is 2 to 4 weeks. Prosthetic valve treatment duration includes 6 weeks. The penicillin sensitive regimen includes ceftriaxone or benzyl penicillin. If there is penicillin resistance, we add vancomycin. Now the dosage of vancomycin is 1 gram 12 hourly, ceftriaxone 2 gram IV once a day, gentamicin 3 milligram per kg per day, rifampicin 300 milligram TDS, and doxycycline 100 milligram BD. Indication of surgery in infective endocarditis. It includes number 1, unresponsive to the standard optimized antibiotic therapy at least 2 weeks. Number 2 is aortic root abscess confirmed on ECG and echo as prolongation of PR interval. Prosthetic valves abscess, large vegetations and fungal cause. These are the indications of infective endocarditis to be treated with surgery. The procedure of surgery includes removal of vegetations and valve repair. Now, in a patient with culture and sensitivity, it's negative in blood, what is the further workup of a CS negative infective endocarditis? Workup includes in this case the serology, that is PCR, blood PCR for fungus and bacteria. We have to work up for systemic lupus erythematosus, colonoscopy for any malignancy of colon, and tissue biopsy and tissue culture plus valve biopsy as well. For fungal infection, fungal infective endocarditis, the serum galactomannan level should be sent in order to rule out invasive aspergilloma. Aspergilloma or aspergillosis, especially the invasive aspergillosis, can lead to infective endocarditis. Treatment and complication of endocarditis we have discussed. Now, complication, it might be a stroke, it can present as stroke, glomerulonephritis, mycotic fungal um, infection. Now, the mortality or prognosis in case of infective endocarditis. With treatment, mortality is 20 to 25%. Without treatment, it is 100% mortality in case of infective endocarditis. Poor prognostic factors in case of infective endocarditis includes large vegetations more than 1 centimeter, aortic valve involvement, that is another poor prognostic factor, old age plus comorbidities, multiple valve endocarditis. So these are the poor prognostic markers. If multiple valves are involved, old age plus comorbids, aortic valve involvement, and large vegetations, and complications, especially stroke, glomerulonephritis, or any other peripheral complication. The streptococcus cure is 90%, while the staph cure rate is 70%. Risk factors and predictors of embolization from the native valve in case of infective endocarditis. It includes that there is large vegetation, large area involved, multiple valves involvement. If there is pedunculated vegetation and mobile vegetation mobility, these are the risk factors to develop a stroke or embolization. Now, acute versus subacute infective endocarditis. The acute endocarditis, infective endocarditis patient looks more toxic. High grade fever is there, and the most common cause is Staph aureus. And acute infective endocarditis resembles more often like acute rheumatic fever. The subacute infective endocarditis, there is weight loss history, night sweats, and the fever is not that high grade but moderate, 1012 102 degree Fahrenheit. And the subacute infective endocarditis is caused by Streptococcus viridans. Immunological complications of infective endocarditis like glomerulonephritis, if developed, so we have to use antibiotics plus steroids plus cyclophosphamide. In mycotic aneurysm, antifungal plus surgical debridement. And empirical regimen includes vancomycin, gentamicin plus ceftriaxone. For aortic root abscess, there is surgery is indicated. Now, embolic phenomena leads to stroke, digital gangrene, myocardial infarction. The immunological phenomena leads to glomerulonephritis, ocular nodes, road spots, and lab evidence of rheumatoid factor positivity and blood culture positive in case of immunological phenomena. So if medical treatment is failed, at the end of 2 weeks, go for surgery of the valve. So this was a discussion regarding infective endocarditis, its cause, etiology, the complications, the fever pattern, and anything which presents uh, acutely in a young age group with fever and an audible murmur or a murmur which is confirmed on echocardiography. Our top differential is infective endocarditis. Thank you very much.